Hi, thank you for joining us tonight for the public health update on Japanese encephalitis and COVID-19. My name is Phoebe James, and I'm a Professional Development Officer with the Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the lands we are all meeting on today and pay my respect to elders past, present, and emerging. I just wanted to mention before we start that this session is being recorded. The recording and the PDF slides will become available on our PHN website in the Education Library in the next few days. We are having a Q&A session at the end of the presentations, so please feel free to put your questions in the box and we hope to get to all of them. There will be an evaluation that needs to be completed, sent out at the end of this webinar, and it would be amazing if you could fill that out. Tonight, we are lucky enough to have Dr. Kirsten Williamson, a public health physician with Hunter New England LHD, Patrick Cashman, an immunisation coordinator with Hunter New England LHD, and Dr. Michelle Redford, who's a GP at Blackbuck Doctors. I will now hand over to Kirsten.
Thank you very much, Phoebe. I'll just try and share my screen and let me know if hopefully you can see that.
Yep, that's fine.
Okay, fantastic. Thank you. So first of all, I want to acknowledge that I'm dialing in from Awabakal land, the lands of the Awabakal people, and pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal members of the meeting here today. So over the next 15 minutes, I'd like to particularly focus on Japanese encephalitis, particularly the disease, the epidemiology, what investigations that we'd recommend and prevention, but also give a brief update on COVID-19 and some other public health issues. So Japanese encephalitis virus, it's a mosquito-borne flavivirus that's closely related to dengue, yellow fever and West Nile viruses. And so it is primarily spread between hosts by bites from infected mosquito vectors, which is the Culex species of mosquito, but in Australia particularly Culex annulirostris. Water birds, particularly wading birds such as herons and egrets, are the main natural reservoir of JEV and are important amplifying hosts. But pigs also play an important role in amplifying the virus. And this means that they can continue this transmission cycle that you see down in the bottom right-hand corner of the slide by reinfecting mosquitoes. However, it's not spread from pigs to people or normally from pigs to pigs. As you can see in this diagram as well, we have humans and horses, and they are considered to be dead-end hosts. And this means that once they're infected, they do not develop sufficient viremia to then infect feeding mosquitoes and continue this transmission cycle. And this also means that you can't acquire infection directly from another person. So across the globe, Japanese encephalitis virus is endemic in 24 countries, particularly in the Southeast Asia and Western Pacific regions. And this means that a population of over 3 billion people are at potential risk of exposure. The disease is predominantly found in rural and peri-urban areas, and this is particularly because this may be where humans live in close proximity to the animal hosts and the mosquito vector. In temperate regions, there is a summer seasonality, but in tropical regions, infections may occur year-round. And so JEV was not previously a disease that we experienced in Australia, but it was first detected in piggeries in February 2022, so February this year. And it was detected in a range of piggeries as we started to look across Victoria, Queensland, New South Wales and South Australia. And from March of this year, it was also detected in feral pigs in the Northern Territory. And so they first came across it in the piggeries because in pigs, one of the most common clinical signs of infection is through birth defects, so mummification or stillborn or weak piglets. Since the detection in these piggeries, there has been active surveillance both in animals and in humans. And so we've been really looking for human and for animal cases across Australia, and including a look back as well, so looking back into the past. And so what they've found is that since January 2021, that there's been a total of 32 confirmed and 10 probable human cases, unfortunately. So within New South Wales, there have been 13 confirmed human cases, followed by Victoria, of which has been 10 confirmed, 3 probable, and you can see the rest of the states there. Fortunately, there's been no human cases to date in the Hunter New England area. However, there is careful monitoring that's occurring by doctors and hospitals as well. Unfortunately, across Australia, 7 of these people have died. So because Australia, and particularly New South Wales, is a temperate climate, it did mean that the JEV cases in humans and animals disappeared over winter. However, unfortunately, on the 18th of November, just gone, the New South Wales Department of Primary Industries has confirmed the first case of JEV in pigs again for this season. And that was found in a property down in southern New South Wales. On this slide, you can see a map, and this shows the local government areas that are considered to be at potentially higher risk of JEV. And this also informs the JEV vaccine eligibility, which Patty will speak to more later. So on that, it is an expert panel to the Chief Health Officer that has advised the highest risk LGAs. And this is based on modelling of climate, waterbird and pig concentrations. And so that's how they've established this yellow area, which would be the LGAs of higher risk or concern. And it's important to note as well that this yellow zone also builds in a buffer zone. So the LGAs that are perhaps at moderate risk, that border a higher risk area, are captured within the yellow areas as well. But it's important to note that this situation is dynamic and it is continually being monitored by New South Wales Health, so these zones will be adjusted accordingly. So in regards to surveillance across New South Wales for Japanese encephalitis virus, there is the long-term New South Wales arbovirus surveillance and mosquito monitoring program. So this was in place prior to the detection of Japanese encephalitis virus, and it would normally aim to detect key arbovirus activities such as Barmah forest virus, Ross River virus, and also monitor the vector populations across New South Wales. And this is to inform public health action and to provide an early warning system of increased arboviral risk. So from spring to autumn of each year, the ASMMP monitors the presence of arboviruses in the environment through the trapping of mosquitoes for virus isolation. Also, they type the species and the abundance of mosquitoes, and they look for detection of arbovirus antibodies in sentinel chicken flocks. And these reports are available publicly on the New South Wales Health website. So here I've just shown the most recent report from, I believe, the 28th of November. So let's go back and check, up to the 26th of November. And so from this, you can see that in the sentinel chickens, there have been no arbovirus detections in the sentinel chickens across New South Wales. There was some Barmah forest virus detected in mosquito traps detected at Griffith. They also look at the abundance of mosquitoes. So unfortunately, it does report that there is a high abundance of mosquitoes, particularly in Moree and Newcastle in our region. It also looks at the environmental conditions, and unfortunately we do all know that there are a number of areas that are suffering from flooding conditions at this time, which is making things very difficult for areas. And then in regards to human arbovirus diseases, so infections in humans, there has been some Ross River virus detected in the previous week. So as mosquito numbers start to increase, particularly with the warmer weather and with the flood conditions that are impacting much of New South Wales, it does unfortunately mean that the risk of mosquito-borne diseases, including JE, over the spring and summer months may increase. So on to Japanese encephalitis, the disease. So as we said before, the transmission or the acquisition is through being bitten by an infected mosquito. And the incubation period is usually about 6 to 16 days. Fortunately, over 90% of JEV infections are asymptomatic, and however, rarely, so less than 1%, those infected with JEV can develop clinical disease, and often this is severe in the form of encephalitis or meningoencephalitis. So that would be presenting as sudden onset fever, headache, vomiting, with progressive neurological changes. And unfortunately, of those who develop severe infection, up to 30% of those people, it is fatal. Of those who survive severe infection, 20 to 30% may suffer permanent neurological sequelae. The important thing to keep in mind as well, though, is that JEV encephalitis can't be distinguished clinically from other CNS infections. So that's why it's really important, which we will talk about later, to do the appropriate investigations as well. On this slide, just draw your attention to the image, which is an MRI showing bilateral thalamic T2 hyperintensity and restricted diffusion. And this is from a case report in the New England Journal of Medicine, which was published in August of this year by Waller et al., of what's thought to be the sentinel case of JEV in Australia, which occurred in a resident of the Tiwi Islands in February 2021. So as part of the surveillance as well across New South Wales, there's also been a serosurvey conducted. As most people infected with the virus will show no or only minor symptoms, this serosurvey was conducted to estimate how many people had been infected with the virus over the 2021-2022 summer period. And so this was conducted by New South Wales Health and by the National Centre for Immunisation Research and Surveillance. And they carried this out in 5 regional New South Wales towns that are displayed on the map here: Balranald, Korowa, Dubbo, Griffith and Temora. These towns were chosen as there was evidence that infected mosquitoes had been present in these areas during the earlier months of the year. And there was also a mix of different risk factors for the spread of the virus. And so you can see from the results on the right that of the just over 1,000 people who were participating in the survey, approximately 8.7% of participants were found to have JEV antibodies in their blood samples, which is equal to about 1 infection for every 11 participants. So these results suggest that there is JEV, unfortunately, in rural and regional New South Wales, and means that residents should take precautionary measures to avoid mosquito bites, particularly during that summer season. So now that this serosurvey is complete, there's just for awareness, there is a serosurvey being conducted by Victorian Department of Health. That's still undergoing but completing soon. Also, Lifeblood or Red Cross Blood Bank is conducting a serosurvey also. And that's looking at blood donors across New South Wales, Victoria, South Australia, and also Tasmania. So all of these results will continue to feed into the risk assessment and surveillance and ongoing public health measures and recommendations. So in terms of managing possible Japanese encephalitis virus cases, particularly in your practice or in the local hospital, it's important to consider now the possibility of JEV or other arboviruses in patients presenting with encephalitis or a compatible illness where other causes of encephalitis have been excluded. So first of all, we would want you to think about and certainly exclude HSV, VZV, and other enteroviruses, and also particularly be thinking about bacterial meningitis and HSV as they are treatable. However, if you are concerned about JEV, particularly in those who've spent time within rural or regional areas or have had extensive mosquito exposure or contact with pigs within the few weeks prior to symptom onset, then on this slide, these are the investigations that we'd recommend. So looking at blood, looking at serum for both acute and convalescent serology, looking for flavivirus and JEV antibodies. And so when I say acute, the initial serology collection, but also then repeating that collection about 3 to 4 weeks later. It's also recommended to take a whole blood tube. So I think in most hospitals it would be a purple tube for culture and PCR. And also, where possible, CSF to go for flavivirus and JEV, PCR and culture, and also CSF for serology as well. And then finally, urine, looking for JEV and flavivirus, PCR and culture. But otherwise, if you have any questions or concerns, speak to your local laboratory, local infectious diseases service, or public health unit for advice on testing. If you need advice in regards to the clinical treatment, then please call infectious diseases services. That's on call for your local hospital. But unfortunately, most of the treatment for especially severe JEV infection is really just supportive treatment. Now on this slide, this is a phylogenetic tree of all of the typical arboviruses. Unfortunately, not all of these arboviruses are in Australia, but I've just brought this slide up just to highlight how closely related all of the arboviruses are. And this means that there's often a cross-reaction when serology is undertaken. So often we might see come through to the public health unit a report that shows a detection for both dengue and farmer forest virus, for example. And this is especially, this cross-reaction can occur for IgM results. And so what this means is that it makes the convalescent or that repeat serology test really important to help distinguish between what is the likely cause of illness. And also means that the exposure history is important. For example, is this serology in a pig farmer working in an LGF concern who has been bitten by mosquitoes? We'd be much more concerned about JEV as opposed to, say, someone living in metropolitan Sydney. But overall, the most important thing is to try and prevent JEV in the first place, and also infection from other arboviruses. So we are recommending that everyone take precautionary measures to avoid mosquito bites, particularly at dawn and dusk. Noting as well that mosquitoes in New South Wales can carry other viruses such as Murray Valley encephalitis or Kunjun virus, not just JEV. So it's important to use mosquito repellent, wear loose and long sleeve or long pants to protect yourself. Make sure you're reapplying mosquito repellent. And this is particularly important if you're working or living near flood areas. Also recommend to avoid keeping stagnant water around your home, such as watering cans or buckets of water where mosquitoes may breed. And if your doors or windows are kept open, then recommend trying to have insect screens there too. Otherwise, looking at vaccination if eligible, which Patrick will speak more to later. So on to COVID-19. We were just reflecting before how much things have changed over the last couple of years, and particularly coming into Christmas, really hoping for a nicer Christmas than previous years with COVID. However, with the newer variants, it does mean, unfortunately, that COVID is re-emerging, and we are seeing and experiencing a new wave in New South Wales, which I'll speak more to later. But I just wanted to point out here that this is a graph that shows the different variants of COVID-19 across New South Wales. So you can see back in July in the blue, that was Omicron variant BA5 that caused the wave in the middle of the year. And you can see that over time, that proportion of BA5 in blue really increased and was the predominant strain between July up to September. But if you look later in the graph here, you can see now that we're seeing these other variants emerge. So BA5 has become much, much less prominent. And instead, what we are seeing now is an overtake of a number of different variants. So in the light blue, we can see BQ 1.1. In the yellow coming up, we can see BR2. And also in the pink, we can see recombinant XBB. And so these are variants that are derived from previous Omicron strains, but it does mean that we are seeing reinfection of people who previously may have had Delta or may have had BA4 or 5, now becoming infected again with these newer variants. So in regards to the cases in Hunter, New England, so there were 3,000 or almost 3,500 reported cases in Hunter, New England in the past 7 days. And that's from both PCRs and rats. However, I'm sure we all know that this is very likely an undercount because there are lots of people who aren't getting tested. On this slide, you can see a graph that shows the COVID-19 rates, so the number of cases per 100,000 population over the past month, so for the month of November. So because we know that not everyone is getting tested, it's important for us to look at a number of different surveillance measures, which I'll show you in a moment, to really understand the trend of COVID-19 across Hunter, New England, New South Wales and Australia. And unfortunately, all of these measures suggest that we are experiencing another wave of increasing COVID-19 at this time. So this graph here shows the confirmed COVID-19 cases in hospital and in ICU inpatients for Hunter, New England. And the graph dates all the way back to 2021, so you can see the waves over this time. The blue bars show the daily number of hospital inpatients. The orange bar shows the daily number of ICU inpatients. And then the red line shows our 7-day average hospitalisation, and the yellow line is the 7-day average ICU admission. And so unfortunately, you can see here again that the hospitalisation is starting to increase, has really started to increase since about the end of October. We're also seeing this reflected in the outbreaks that we're assisting with in aged care and disability care facilities. So again, the dark blue bar here shows the daily aged care facility outbreaks, which involves cases of COVID-19 in 2 or more residents. The light blue bars are the daily disability care facility outbreaks, and then the yellow line shows the combined 7-day average. And so although we're not at the level that we were previously, so particularly earlier this year with the BA5 wave, or towards the end of last year with the Omicron wave, we can see that unfortunately it is increasing again there. It's also reflected in flu tracking, so that's a voluntary participant online survey across Australia, but there are a large number of participants from Hunter, New England as well. And so you can see back in 2019, that blue line shows respiratory illness, so fever and cough, in the population prior to COVID-19 pandemic. So that would allow for other respiratory illnesses, particularly flu as well. You could see how that really dropped off as we kept COVID-19 under control. The closure of international borders and things like that kept other respiratory illnesses out. We had very little flu for that time. But then from the end of 2021, we could see that Omicron wave start there again. And you can see here at the end that those fever and cough activity is coming up again now. Importantly, when they've surveyed the participants of flu tracking, the percent positive of participants who are testing positive for COVID-19 is increasing as well. So we can see that cough and fever activity is most likely due to COVID-19, not due to flu. And finally, we also use the sewage surveillance, so looking for fragments of COVID-19 detected in sewage. And that's across New South Wales, across some key sites. But particularly here, you can see for the Hunter, New England areas, for Armidale, Tamworth, Tyree and the Hunter region in the red is where the COVID-19 sewage detections are increasing, and then the yellow is where it's then stable. So what does this mean? It means that, particularly if we want to hopefully have a nicer Christmas this year than previous years, is that what we need to be doing is encouraging patients to keep up to date with their vaccination. We recommend preparing a COVID-19 plan for patients who are at risk of severe disease, and also going back to those general sensible measures. So hand hygiene, socialising outdoors, masking if you're indoors and can't physically distance. At the moment, for Hunter New England Local Health District, we are in an amber alert, which means that we are wearing masks both in patient-facing areas, but also in non-patient-facing areas as well. And of course, stay home and test if people are unwell. So just a really good time to reinforce those messages with family, friends, patients, everyone. And just to finish off, I just wanted to touch on briefly on a couple of other issues. So just a reminder that it is the holiday season and we are seeing a lot more travel happen at the moment as well. So it's a good time to remind patients of their travel vaccines. Overseas, there are a number of areas with measles outbreaks, also typhoid outbreaks, particularly around Middle Eastern countries, with instances of extended drug-resistant typhoid as well. And then also it's important to remind any adventure travellers to be up to date for their tetanus vaccine. On that note, just a reminder that MMR vaccine is free in New South Wales for anyone who's unvaccinated, and otherwise, just a reminder to have a high index of suspicion of these travel-related diseases, particularly measles or causes of vomiting, diarrhea in returned travellers. And finally, just a couple of other little reminders of what we're seeing at the moment at the public health level. So we are seeing quite a lot of viral gastroenteritis, particularly in childcare centres. So just a reminder that if, however, you are concerned about a non-viral presentation in a patient, so perhaps a prolonged gastro illness or bloody diarrhea, to still consider non-viral causes and send that person for a stool specimen for MCS and PCR. We've also seen a number of people with exposures to bat bites or scratches. And so just a reminder that even if it's a trivial exposure, this can be important because about 1% of bats in Australia, all types of bats, may carry Australian bat lyssavirus or rabies-like virus. And so it's important that the person be assessed for potential rabies post-exposure prophylaxis. And so if you are concerned about that, please call the public health unit and give your advice. Unfortunately as well, we are coming into the higher season for meningococcal disease. And we have seen a number of cases, particularly of serogroup B across New South Wales. So a reminder to just bear that in mind if you are seeing someone unwell with fever, making sure that you're safety netting parents of children with fever as well, and promoting meningococcal vaccine to children and young and adolescent patients. Then finally, zoonoses. So we do often see Q fever, leptospirosis, and fortunately lepto has not been as high as it had been previous years with the mouse plague, but it still is around, and also brucellosis in people with exposures to pigs, particularly wild pigs as well. So on that, I'll finish up, and I'll hand over to Michelle.
Thanks, Kirsten, for your wonderfully informative presentation. I'm going to get my presentation up and then we'll get going. So I'm just going to be talking about a few issues that are relevant to primary care. Nothing too complex, but following on from what Kirsten's been saying. I'm a GP in New Lambton and I'm also GP advisor to the Hunter New England Central Coast PHN. So just a reminder, as always, that the health pathways are your go-to place for any referral or management information. This is the Hunter New England COVID-19 pathway, and it has it's kept up to date by a fabulous team, and you can find everything that you need on there. So the first thing that's changed is that from the 1st of October, the Medicare rebates for pathology changed, so that they're not automatically getting a rebate for RSV and flu testing. So what is happening is that if you go to a drive-in, you'll get tested for COVID-19, but you would need a referral if you want to be tested for RSV and flu. So just be aware of that. I'm not sure what is happening beyond the end of December, but at the moment, patients can still self-refer for COVID-19 testing. But this links into something I'm going to talk about a bit later on about preparing your high-risk patients, and it might be worth them having a referral for more extended viral testing, depending on the circumstances, so that they can have access to a more extensive PCR. So just to be aware of that. So planning for high-risk patients, the link at the bottom takes us to the newly released New South Wales Health GP antiviral pre-assessment form, which I'll show you in a second. But the idea with this document is that it allows you a framework to discuss the risk in advance with your highest risk patients. It does not act as a prescription. So when your patient tests positive to COVID, they still need to have a medical assessment. But it does allow you, maybe when you have more time and you're not trying to squeeze someone in, to make a plan for testing, check interactions with, particularly with Paxlovid, look at eligibility, think about whether you would give antivirals for flu, you know, thinking about what the EGFR is as well for dosing for both Tamiflu and for Paxlovid. And potentially, if you're keen and you're digitally savvy, you can upload this thing to the MHR so that anyone can see it. So I'll take you through a bit about what that looks like. The other part of this, of course, is educating our patients about them being high risk. And I was on the webinar the other day from New South Wales RACGP, and they were saying then that most of the over 70s have fairly good awareness that they're high risk, but the groups that we really need to remember to remind and to discuss risk with would be those people who are Indigenous and aged 30 plus with one risk factor, or non-Indigenous aged 50 plus with two risk factors. They potentially are not aware of their eligibility, so worth looking out for them. So what is this form? What does it look like? Here it is. This is pages 1 to 3. And I suppose it's a bit wordy because it's actually taking you through what's quite a complex process, but you know, it's the demographics and then really thinking about what the risk factors are and whether people are eligible, whether they've got contraindications to Paxlovid specifically, and checking interactions, then checking the renal function and knowing what the dose would be, and then similar for influenza. And then this is, you know, some more pages, and it's got a little bit of an action plan for the patient written down on there about getting a PCR test because they're high risk. So it's comprehensive and it's a good way to plan, but it doesn't replace a prescription. They still have to have an assessment. We've been doing this for a little while, this sort of giving people a letter that says, you know, it's a bit more simple, and just saying, you know, if you have symptoms, then do a RAT at home, and if that's negative, go and take your form and get a PCR test. So what we've been doing is giving people a laboratory test request that they can then take if we think that we want more than just a COVID-19 test. And mostly the idea was that then we might actually get notification from the lab that the patient's got COVID-19 and be able to do something about it fairly quickly. So that's about planning. Other couple of things that have come up recently. So on the PBS now, you can get antivirals for your doctor's bag. Like if you're working, doing a lot of out of hours or rural or remote, you can get up to 2 courses of both Lagevrio and Paxlovid for an urgent supply per month. So that's just something to be aware of. And then, as Kirsten said earlier, New South Wales Health has moved from yellow status to amber. This is the COVID-19 risk monitoring dashboard, and went to amber, I think maybe a week and a bit ago. And what that means is that there is mask wearing in all areas, including in the back offices, unless you're the only person working in the office, and still eye protection when within 1.5 meters of a patient. So it's probably not a massive change for most places, and we have been continuing to enforce surgical mask wearing for patients and visitors to our practice. Of course, there is nothing that is mandatory in the same way anymore now that we don't have the public health orders, but as private businesses, we can make our own determinations about entry criteria. So just a reminder about that. And that's all I've got, and we'll be answering questions at the end, so please put them in the box, and I will hand over to Paddy, who's going to talk all about immunisation. Thanks, Paddy.
Thanks, Michelle. Can you see my screen?
Yeah, all fine.
Oh, great. Thanks, Phoebe. G'day, everyone. Thanks for joining in, and thanks to Kirsten and Michelle for those. That's great information. So you've got vaccines in your fridge, so we need to get them out to people because we know what life without vaccines is like. You have to shut down and wait for a vaccine to be produced before we can give it to people and open up again. So that's no fun. So vaccines make a big difference to how we run our community, how we run our society. You can't run an economy without vaccines. And tonight, because of the floods and the new incursion of Japanese encephalitis to New South Wales, we're talking about that first off. There's a great fact sheet for Aboriginal communities. If you're working with Aboriginal communities on the New South Wales Health website, thoroughly recommend that you get that out to communities. So there's obviously, we want to stop people getting bitten by mosquitoes. The mosquitoes and the water birds interact and share the virus. Like Kirsten was saying, we probably can't do much about the water birds, but we really can do a lot about the mosquitoes. So it's really, really important. We're used to having these conversations with travellers. It's now important we have it with locals. But it's a vaccine preventable disease. We don't have to shut things down and wait for a vaccine to be produced. We've got vaccines. So that's terrific. So Japanese encephalitis, now there's not much vaccine about because we sort of weren't expecting a lot of a new wave of Japanese encephalitis in New South Wales. The vaccine's expensive and it's difficult to make. So it runs in batches of 2 or 3 months per year, and the main vaccine we're using in Australia is made in Austria. So Kirsten talked about the areas in New South Wales. So this is the areas where with the recent floods, there's a lot of water birds and there's obviously a lot of mosquito breeding at the moment and will be over the coming months. But there's a buffer built into that. So in our area, the Moree Plains LGA is part of where can have free and eligible vaccine, but we have no cases there. So there's a big buffer built in. To the map, so you don't have to build a buffer by offering vaccine to people who aren't in that area. But the vaccine, even in those areas, it's still only available to people who spend a significant time outdoors. So that's about 4 hours. People involved, displaced by the flooding or involved in flooding recovery, and also down the bottom there, if you work in a piggery or you're entomologist, you're working a lot with mosquitoes. So they're the high-risk people. So you think, oh, you know, I don't work in a piggery, but I go pig shooting. Well, then you probably come in under the 4 hours a day outside and probably qualify for vaccines in those geographical areas. So Japanese encephalitis, it's been around for a long time, first identified in people and horses in the 1800s. And then 100 years ago, we seem to get, there's another outbreak 100 years since an outbreak in Japan, which of course where it gets its name from. And the virus was isolated in 35. So it's new to us in New South Wales. Big news, but it's not new globally. It's been in Southeast Asia for a while. Now, there's some graphs at the top from China, Japan, and Korea. There's a lot of detail in there that I won't go over, but what you can see is that on the left-hand side of all those graphs, there's lots of disease, then the vaccine's introduced, and on the right-hand side, it goes right down. So these vaccines work really well. This is a vaccine-preventable disease. And on the very right-hand graph, you can see there, particularly for children. So this is a disease of children. So that there's, on the bottom right is the current Vietnamese schedule. You can see there the Japanese encephalitis is just on the regular schedule, and it's given about the 12-month of age mark. So if the virus becomes endemic in New South Wales and the vaccine gets onto the NIP, the National Immunisation Program, we'll probably see it about that 12-month mark. There's 4 classes of vaccines. There's a vaccine we used to use, JE-Vax, you might remember. For people who've been around for a while, we used to use that in the 90s, got discontinued because of side effects. There's a live vaccine made and used in China that works really, really well. That's a great vaccine, but that's not available here. We have 2 vaccines available here, an inactivated vaccine called Jespect and a live vaccine called Imagev. So Jespect is a inactivated vaccine, so it's not live, which means we can give this vaccine to pregnant women and immunocompromised people. And this vaccine can be given to infants from 2 years of age. It's a 2-dose course. So you think it's a inactivated vaccine. So like a lot of the inactivated vaccines we use, you need more than 1 dose. So you think about the Infanex Hexa we give to kids, we give it at 6 weeks, we give it at 4 months, we give it at 6 months. Because it's inactivated, you need to give boosters and reminders. So it's 2 doses, 28 days apart. So for kids between 2 months of age and 3 years who spend 4 years outside in those LGAs who qualify for the free vaccines, it's a half a dose, 1/4 ml, again 28 days apart. Kids over 3 and adults get 2 doses of the half mil. Now, this is an expensive vaccine. It's difficult to make, and there's not a big supply. And this incursion into New South Wales was new. It didn't get flagged. So the vaccines that have been manufactured have already been distributed to countries in Southeast Asia. So there's not a lot available for us to buy. So you can only order it in very small amounts. So if you're sitting in Moree and Narrabri in the LGAs, then you just want to have a very small amount of this and be giving it to people who can't have the live vaccine. So that's pregnant women and people under 9 months of age who are over 2 months of age. So this is not something we overstock on. But if you read the product information, it says it's only for people over 18 years of age, but ATAGI recommends it can be given from 2 months of age up to 18 years of age. Now, Imagev is the live vaccine. That's the other vaccine. We have more of this. We don't have a truckload, but we've got more of this. It's a chimeric vaccine. So a chimera from Greek mythology it's a particular beast with it's a lion and a goat in the middle and a dragon or a snake at the end. I suggest we don't use these images for patient information. So the vaccine's called chimera because it's things stuck together. And in mythology, it became chimeras, just things stuck together. This is the classic, but other beasts stuck together are still a chimera. So you can see on the top right here, this is why it's called a chimera, because this live vaccine, the Imagev vaccine, the one we have more of, it's the vaccine antigen for the yellow fever, the vaccine strain of the yellow fever virus is the inner, and then this second bar here is these outer antigens from Japanese encephalitis, the PRM and the E antigen. So that's the shell is put on the outside of the yellow fever vaccine, and that's grown in cells. And then this is what you end up with the inner of the yellow fever vaccine and the outer, the green spiky bits there, the antigens for Japanese encephalitis. So that's why it's called a chimera, because it's 2 things put together. So it's a live vaccine. Now, live vaccines work really well because they're live. They imitate nature really well. They replicate, you inject them in, they replicate, and the immune system recognizes them as a true invader, and you build up really good immunity. So you only need the 1 dose, but it's only licensed for people over 9 months of age. So for children between 2 months and 9 months who are spending a lot of time outside in those LGAs where people are eligible, you'd use the Jespect vaccine, and you reserve that vaccine for people in that age group, pregnant women and severely immunocompromised people who can't have the live vaccine. So the Imagev, you need to reconstitute that. It's got a freeze-dried pellet. Now we're getting lots of reports that the the diluent that comes with it, it's supposed to be 0.5 ml, but in lots of cases, it's only sort of 0.4 of a ml or even slightly less. So the current advice is just use the full diluent. You don't have to not use that vaccine because it's slightly less diluent. So just use all the diluent in the container. Once you've reconstituted it, you need to reconstitute as you go because it's only good for an hour after you reconstitute it. So yes, single dose for people over 9 months of age. It's a live vaccine and it's distributed by Sanofi in Australia. So some important considerations that if you're giving this vaccine to people who could be pregnant, you would use the other vaccine, the inactivated vaccine. And then because it's a live vaccine, we don't use it in conjunction with immunoglobulins or immunoglobulin containing blood products. You need to delay for 3 months. It can be administered on the same day as other live vaccines, but if they're not given on the same day, then you need to leave 4 weeks between another live vaccine, which is an MMR vaccine or a yellow fever vaccine, and the Imagev vaccine. So they can be given, live vaccines can be given on the same day. If not on the same day, need to separate by a month. But there's no interval between a live vaccine and an inactivated vaccine. So you could give the Imagev today, you could give a tetanus booster tomorrow, no dramas. Now there's a lot of issues because it's not very available. There's a limited production and long lead-in times. It brings up a lot of ethical issues. So because Australia is a rich country, there's potential of diverting the supplies away from other poorer countries. There's about 130,000 doses we've purchased of Imagev and Jespect, of which most of it is Imagev. We have to be very sparing of the Jespect for people who can't have that live vaccine. It's distributed on the basis of risk. Now, what we could do in the future, we're not doing it at the moment, but because the skin is obviously where your body meets all the bugs and keeps them on the outside, that's where you've got fantastic immune response. So if you give a vaccine on the right-hand side here intradermally, which is what's happening with monkeypox vaccine at the moment, and you're used to doing it with Q fever testing and sometimes used for vaccine sparing, dose sparing for rabies vaccine, then you get a really good response. So you only need a much smaller amount. On the left-hand side is a traditional subcutaneous, and a bit deeper would be intramuscular vaccine, where you need a larger amount because obviously the immune system's not used to fighting diseases and bugs in the muscle. It's used to doing it in the skin. So for people who want to do a bit of upskilling, I suggest that learning how to do intradermal administration of vaccines might be something good in the future. And of course, you would have heard of the patch technology for vaccines. That's why those work so well. And I thought we would have them by now and needles would be in the past, but that's not the case. I was completely wrong. But hopefully in the future, we'll get vaccine patches. If we're going to give vaccines out, we need to do it safely. And if you get any adverse events that aren't normal, so obviously getting a fever and a headache, fatigue is normal. We don't need to report that. But if you get adverse events of concern, please report it on the regular reporting form. Just search for National Adverse Event Reporting Form. It'll come up, and send that in to us, and we will process that for you and be in touch and get more details. So it's really, really important that the general public's frightened about they think we're hiding things about vaccines and things. So we've got to be really transparent. If you give someone a vaccine, they have an event, then please let us know. We need to report that on. We want to be really honest. That's how we found out about the problems with the AstraZeneca vaccine is by good reporting. So it's really, really important that that happens. So if you're going to give the vaccine, you must be prepared to report any adverse events. We'll talk about COVID vaccines quickly. So the primary course is recommended for everyone in Australia over 5, and boosters are recommended for people over 50 and people over 16 with disabilities or chronic conditions, and a second booster is permissive if you're 30 to 49. Now, the bivalent vaccines are available. So the Moderna has been available for about 6 weeks. Pfizer should be available from next week or very soon. They're for boosters only. If you're giving primary course, we use the other one. It's obviously got the original strain in it plus the Omicron BA1, 3-month interval, the regular 3-month interval, and at the moment they're just licensed for people over 18. Now, if you're working with Aboriginal communities, we're still really need to increase the rate. So the top data here is people in the Hunter, New England over 50 years of age. This is data from last week. And you can see on the bottom right here that this is fourth dose, that 54.4% of people over 50 have had a fourth dose. Whereas the bottom graph, the second bottom line on the right-hand side, only 33.9% of Aboriginal people over 50 in Hunter, New England have had a third dose. So if you're working in an AMS or you've got Aboriginal clients or you're working with communities, really important you encourage that fourth dose. Now, giving back COVID vaccine to children, they don't get as much disease. So should you be doing that? They're difficult conversations. So to help you with those conversations, or people who are asking, you don't need a long consultation, you can direct them to this new decision aid on the NC's website, and they can go through that themselves and save you some clinical time having those complex conversations. But for younger children, the recommendations for a third dose have changed recently, and this is quite complex. So the message here is to double check. The fact sheet on the left is really helpful, and the table on the right in blue comes from that fact sheet. So if we weren't giving any, so if you're between 6 months and 4 years of age and you don't have any high risk conditions, there's no third dose recommended. There's no dose recommended at all. So if you're a healthy kid under 4, we don't give any doses at all. But if you're between 6 months and 4 years, you've got severe compromise, then you get a standard 2-dose primary course of the pediatric vaccine and a third primary course. So you can see here there's no booster dose for children under 12, but a third primary dose is recommended in severely immunocompromised. So if you're working with young children who are severely immunocompromised, then you need to refer to the current information and see whether a third primary course is recommended. But over 12 years of age, you can see here 12 to 15 years with severe immunocompromise, they can have the third primary course plus a booster. So it's quite tricky in this age group under 12, and even simple things. So the vaccine, the Moderna vaccine, is licensed for 5 to 11-year-olds, but the Pfizer's 6 to 11-year-olds. So there's lots of traps in there. So if you're giving vaccine to younger children who are severely immunocompromised, do double check what you're doing and check the recommendations. But you do have a lot of other vaccines in your fridge. Meningococcal disease, there's just a picture here of a kid from the States who've lost their arms, and you would have seen that in your clinical practice. So for young Aboriginal kids, on the bottom left here, that younger Aboriginal kids aged less than 5 years are 5.5 times higher than other children in Australia for getting meningococcal disease. So Bexzero is recommended and funded for Aboriginal children at 6 weeks, 4 months, and 12 months. And there's a catch-up for kids under 2 years of age, but that finishes at the end of this financial year. So 30 June next year, that catch-up goes off. So really, really important that you catch up all your young Aboriginal patients less than 2 years of age if they've missed the primary course at 6 weeks, 4 months, and 12 months. That's funded for all Hunter, New England. And just a reminder, we fell a bit behind with a lot of the regular childhood vaccines during the pandemic. Like there's a lag with a lot of the general practice work, and regular vaccines is part of that. And also a reminder for people working in the flooded areas in Gunnedah, Moree, Narrabri, Wee Waa, tetanus vaccines, keeping tetanus vaccines up to date is really, really important. We tend to put that in the background and forget about it, but really, really important that people are up to date with those vaccines. So a new feature on your practice software, best practice, or Communicare, or medical director, is web services. Now you can get two-way communication. So we're used to putting stuff into the medical software and then separately adding, looking up stuff on the AIR. But now the AIR will communicate. If your software is up to date, it'll communicate. So when you bring up a child, you'll be able to see their record, and you'll be able to see, so if mum comes in with a few kids, one's the patient, you'll be able to check the other ones very quickly on your practice software and catch them up with any needed vaccines. So talk to your practice manager and make sure your practice software is up to date so you can use the web services. That's really, really handy. Another important rural disease, Q fever. This will bring big strapping farmers down and put them in bed for a few months. It's terrible. So this is Q fever data from New South Wales for a decade up to September this year by age, and you can see that the dark blue is females and the light blue males, and you can see there the middle-aged blokes, who are the sort of the average age for farmers, are really overrepresented. So although this is not a vaccine we give to someone who's been vaccinated before or who's been exposed to the Q fever, it's not too late. It's not too late. So if you've got working with rural populations and middle-aged people and they haven't had the Q fever vaccine, it's worth doing the skin testing to see if they've been exposed. And also you can see there a huge rise in older teenagers. So this vaccine's licensed from 14 years and up. So for teenagers and for middle-aged people, really worth doing that testing and protecting them. Now, monkeypox, this is a vaccine you don't have in your fridge, but if you're working with men who have sex with men or other people at risk, then refer them, you can see on the bottom right here, to the Tamworth Sexual Health Clinic or to the Wallsend Vaccine Hub. They've got monkeypox vaccine there. So people will have to travel for this vaccine from western part of Hunter, New England. That vaccine's free and available, although you don't have it in your fridge. There's just some graphics here from a bloke who put his experience up on the internet. So it's quite a nasty infection that it's well worth protecting. Again, vaccine preventable. Who would have thought the smallpox vaccine, similar to what Jenna was using all that time ago, is now used for this new outbreak of monkeypox. So our website has lots of information. Encourage you to go there if you're looking for information. And please keep in touch with the immunisation unit, and keep vaccinating, because it's how people have fun. Thank you. Now we'll just have a look to see if there's any questions. There's a question here from Fiona. Why is the isolated small area on the map high risk? That's a good question. I had a look at that. I don't know which area it is. I assume because they had a case there, Fiona. Do you get any insight into that, Kirsten?
Yeah, so I just double checked. So that LGA, I believe, is Goulburn, and unfortunately they did have a human case there. I don't know anything further around, say, the details of that case, whether they had potential exposures in other LGAs, for example, but I believe that's why that LGA is included.
Oh, wonderful. Thanks, Kirsten. Hopefully that helps, Fiona. And there's no other questions in the thing. So someone's got a minute or two to type quickly? No, that's it. Fantastic. All right, that's great. Well, hopefully that helps, but do be in touch if you do have further questions. Michelle or Kirsten, did you have anything to add at the end?
No, just to say thank you, and I think it will all be on the website afterwards, won't it? The recording for people to watch at their leisure.
We did have a last-minute question come through.
Oh, yeah.
Eleanor Spence has been to Balranald. I've probably butchered that.
Balranald. Yep.
Thank you. Should she worry?
So, in short, overall, I would say still the risk of acquiring Japanese encephalitis is small, but also the risk of developing clinical disease or symptomatic disease is less than 1%. So hopefully that's reassuring in itself. I suppose the other question would be how long ago it was that you were there and what you were doing in that time. So noting that the incubation period is usually 6 to 16 days. If it was some time ago, you're probably quite reassured now as well. But also really around that exposure to mosquitoes and infected mosquitoes, which at the moment this season we haven't had Japanese encephalitis detects in trapped mosquitoes. It's not to say it's not there, but it hasn't been trapped yet. It's just that we have seen the detection in piggery recently to suggest that it could be beginning to recirculate again.
Okay, thank you. She did clarify, Eleanor did clarify that it was during the floods and about a month ago.
So hopefully being past the 16 days, hopefully that's becoming more reassuring as time goes on for you.
All right, well, thank you so much. I want to thank everyone for attending, and Patty, Michelle and Kirsten, thank you stepping up last minute to provide this update. It's really important and we really appreciate taking the time out of your usual days to present and put together your presentations. And I probably won't see you before Christmas, so Merry Christmas and Happy New Year, everyone. Stay safe and look after each other.
Thank you.
Thanks very much.
Thanks, Michelle. Thanks, Kirsten. That was good. Oh, I can't hear you, Michelle.
Are we still on?
I think it's just us, but yes, maybe not. So be polite.
Yes. Well, yeah, lovely to see you. I'm going to leave now and I might end the webinar for everyone, I think.
Mm.
No
Okay.
worries, lovely to see you too.
Okay.
Thank you.
Thanks.
Bye.
All right. Bye.